everyone. I'm Christophe with your EMIM, and we're going to talk today about ultrasound-guided upper extremity nerve blocks. So I'm going to talk a little bit about just general nerve block considerations with any nerve block. We're going to talk about the neuroanatomy of the upper extremities, and then we're going to talk about some specific nerve blocks, looking at the indications, the local anatomy, and techniques for localizing the nerves. So first, why use a nerve block? Analgesia to help prevent pain or to potentially help with somebody who already has pain. They're great because they're pretty predictable in terms of time. So time to onset and duration of analgesia. And you can kind of customize it to your patient. Do they need long acting? Do they need short acting? They're also great because they're opioid sparing. So the more analgesia you can get through a local anesthetic, the less of an opioid you're going to need. And then finally, you get to avoid a lot of the systemic side effects that you get with giving a PO or IM or IV medication. For most of your nerve blocks, you're going to want to use the linear or vascular transducer because most of your nerve blocks are going to be in very superficial areas. And so that's where this is what you're going to get the best resolution with. There are some blocks, if you're a little bit more advanced, that you may be using a curvilinear probe for, but the ones I'm going to talk about today, we're going to be using a linear transducer. And then when you're using that linear transducer, you always want to remember in plane versus out of plane. So on the, does that work? Okay, so on the right of the screen is an out of plane view. That's how we do most of our ultrasound guided IVs. That's not generally how you want to do your nerve blocks. You really want to try to be in plane so you can see the entire needle as it's going into the tissue, what vasculature is around it, what other structures, and really get a good idea of what you're doing. And kind of along that line, you really do want to have a little bit of an understanding of kind of nerve anatomy, just very basic, just so that you don't cause complications in your patients. So if you remember back from anatomy in med school, you've got your peripheral nerve that's surrounded by an epineurium, and then you've got a bunch of fascicles, and each fascicle is surrounded by a perineurium. You generally want your anesthetic to coat the nerve. You want to bathe the nerve in the anesthetic. You want it to be outside of the epineurium. That's going to be your best bet. Generally, you don't want to puncture that epineurium. There's a little bit of mixed data in the literature about how much damage will actually result and whether it's going to be permanent or just or going to be self-resolving. But in general, you're likely to cause some nerve damage if you do puncture that epineurium. And you really, really don't want to puncture the perineurium and get inside the fascicles. You're liable to cause very permanent damage in your patient's nerves if you do that. And so along those lines, you really want to think about the needles that you're using. So for most nerve blocks, you want to try to use a blunter or a needle that's specific for nerve blocks if you have them available, maybe a spinal needle, so that you cause less damage. So what you see in this image here is on the top, we've got kind of a normal needle like we use for IM medication administration, and the bevel on here is a long bevel. And so it's very pointy, it's very sharp. These are what you generally want to avoid, although, with most of the blocks that I'm talking about today, those that are forearm blocks, if that's what you have available, it is okay to use them. But generally, you want to use something like on the bottom where you can see the bevel is much shorter and it's kind of considered a blunt tip needle. These are better for nerve blocks because they're less likely to puncture that epineurium or puncture that perineurium. Though if they do puncture it, they likely will cause a little bit more damage overall. In addition, you want to think about the length of your needle. So if you're doing an axial block, say on the brachial plexus or something that's close to the axial, yes. You want to try to use a shorter needle so that you're less likely to interact with things that you shouldn't be touching. Similarly, you want to think about what anesthetic you're using. So like I said earlier, local anesthesia for nerve blocks is great because you can kind of time and customize to your patient. So if we look at something like lidocaine, it's a pretty rapid onset. onset within 5 minutes, and it's going to last maybe an hour, hour and a half. So this is fantastic for those patients that you have a laceration, you just need to get some anesthesia so you can stitch it up, or you have a fracture that you need to reduce, but you don't necessarily want long-acting anesthesia. On the other hand, something like bupivacaine is a little bit longer acting. So it takes a little bit longer to have onset, but it's going to last longer. So that's going to be better for your patients who, say, have a procedure planned, but not, right around the corner. So maybe your hip fracture who's not going to the OR until tomorrow, and you want to just help control their pain throughout the night. And you really want to be able to kind of know what you're using and how long it's going to act so that you can discuss it with your colleagues, your consultants who are concerned about, are you going to take away my neurological exam of this extremity? And you want to be able to tell them, it's lidocaine, it should be off in an hour and a half, so that if there's anything lingering beyond that, that it's likely related to the actual fracture itself or the injury. Any of these are going to be, the duration is going to be enhanced if you add epinephrine. You also want to know kind of what volumes to use, because with nerve blocks, you often are using a little bit more volume than you would be using if you're just doing a local anesthesia around a wound. And so you always want to remember that you're not necessarily going to recall in your mind how many mgs per kg and whatever you can do for each of the anesthetics. So I think it's always good to just look it up, calculate it before you do a nerve block. I actually didn't realize before I did this that MD-Calc had a calculator. I was using a different app on my phone. But there's a great calculator. Just put in your patient's weight and the concentration of what you're using, and you can see how much you can use safely. And that's going to be great because then you can actually document that. So that, if you're admitting the patient and they need to redose, they know how much they can add, how much additional volume they can give, and what's going to be safe for the patient. So let's move on to anatomy. Sure, you all remember memorizing the brachial plexus in medical school. I know I loved it. We are not going to go into all that today, but you do need to know just that generally the brachial plexus, C5 through T1, comes out of the spinal cord and innervates the upper extremity. And the main nerves that I'm going to be discussing today are the radial, the median, and the ulnar, which Dr. Mazzio actually spoke about earlier today in her topic review. So radian nerve innervation, the dorsal aspect of the forearm, the dorsal aspect of the lateral part of the hand. The median nerve innervates the anterior aspect of the lateral hand, and the ulnar innervates the medial portion of the hand. Important to note that dermatomal distribution is not going to be the same as your bony distribution. So with the ulnar nerve, as you can see here, it actually does line up pretty decently. You get that just kind of that medial aspect of the hand and digits. However, when it comes to the median and radial nerves, it's all over the place and is variable between people. So if you've got a bone that you need to block in the forearm, you're probably going to be better off either doing a block that's higher up, more proximal in the limb, or just blocking all three to make sure that you get good anesthesia. So first patient we're going to talk about, this is a patient who was cleaning at home. They went to grab some dishes out of the sink, and they grabbed a knife, and they came in with a nice laceration right over the thenar eminence. And Dr. Mazzio, can you tell me what kind of block we would use to block this? Exactly. So that's going to be a median nerve block to block the lateral aspect of the palmar surface of the hand. And importantly, the median nerve is going to be great for hand procedures, wrist procedures like lacerations, deep abscesses that you need to drain. In cross section, what's important to know is that your median nerve is going to sit right between your flexor digitorum superficialis, which is the blue asterisk, and your flexor digitorum profundus, which is the yellow asterisk. And these both sit right above the interosseous membrane. So on the ultrasound, this is kind of what you're going to see. This bright structure right here is the median nerve. You've got your FDS up here and your FDP down here. So in terms of actually finding it with the ultrasound, the median nerve does tend to be the easiest to find. However, I think the easiest way is to start in a view like this with your probe transverse in the forearm and at a really high depth so that you can see all the way down to the interosseous membrane here in yellow. And you know right above that is your FDP, just above that is your FDS, and your median nerve sits right in between. And so what you can see is as he decreases his depth here, you can see that the median nerve just comes directly into view, and you can really easily then just insert your needle and get a block right around that. So next patient, this is a long night you're working. Next patient comes in, it's 3 a.m. and he was in a bar fight, went to punch somebody, punched a brick wall instead, comes in with a 5th metacarpal neck fracture. Anyone tell me what block we can use to fix this? I hear ulnar. Perfect. All right. So yes. And so remember, your ulnar nerve, you're going to get the same, generally similar innervation to both the bones and the dermis, unlike with the radial and the median nerves. And so your ulnar nerve is going to be similar to the median nerve. It's great for lacerations, abscesses that you need to fix within that distribution, but also for things like boxer fractures. Finding the ulnar nerve, there's a couple of ways to go about it. The first way is to start at the medial epicondyle and the olecranon. So if you feel in your elbow at right where your funny bone is between the olecranon and the medial epicondyle, you feel that little groove, and that's the cubital tunnel. Your ulnar nerve runs right through there. So if you start with the ultrasound right there and then move distally, then yes, just like that, Chrissy, move distally, then your ulnar nerve is going to pop right into view. And I'll show you that in the next slide. The other way to go about it is to actually just find the ulnar nerve with your ultrasound at the distal around the wrist, and then move proximally so that you get some separation between the ulnar nerve and the ulnar artery. And I'll show you that. So this is kind of what you're going to be looking at in cross section when you find it. You're going to see the ulnar artery is right here, the ulna is right here, and the ulnar nerve is between. So always remember the ulnar nerve is going to be ulnar on the ulnar side of the ulnar artery. So in order to find it, if you see in this GIF here, he's starting right at that funny bone between the epicondyle and the olecranon and moving distally. And you can see the ulnar nerve pop into view right there, right? And then the other way to do it would be to start distally and move proximally. And so what you can see is you've got the ulnar artery right here, ulnar nerve. He's getting some separation between it as he moves up and ends up with a view like this: ulnar nerve, ulnar artery. And then you've got a great view. You've got some good separation between the artery and the nerve, and you can inject your anesthetic safely. Next patient comes in, uncontrolled diabetes, says their hand's been getting redder, and now it's got some pus. You know you're going to have to do an IND of this patient. And so you decide to do a radial nerve block because the radial nerve innervates the dorsal aspect of the hand, including that area near the thumb. Radial nerve block is going to be great for hand and wrist procedures like abscesses, like lacerations, and potentially in conjunction with the median nerve block and an ulnar nerve block for some bony abnormalities. So in finding the radial nerve, your landmarks that you're going to be looking for are going to be the radius and the radial artery. This tends to be a little bit more difficult to find than the ulnar nerve or the median nerve because the radial nerve tends to be a little bit smaller, a little bit less echogenic, and so a little bit tougher to find. But I would generally use a similar approach as for the ulnar nerve. So you're going to try to, if you just palpate the radial artery, put your probe over that, then the radial nerve should be on the radial aspect of the radial artery. So you've got your radial artery here, your radius here, the radial nerve should be between the two. And so in the same way that you do with the ulna, here you go, sorry, another one, you've got radial artery here, and then this is your radial nerve, this is your radius. And what you're gonna wanna do is move proximally along the radial artery and radial nerve to try to get some separation between those two so that you can safely inject. And so you can see here, it kind of slowly moves away, and you can see that he's pointing with the arrow following the radial nerve. The final block that I want to talk about has to do with shoulder dislocations. I'm really excited to talk about this one because I never got to use anything like this before. So you've got someone, a 50-year-old guy, he fell down the stairs, comes in with a shoulder dislocation. ED's busy, you really don't have the nurses for procedural sedation, and you're trying to figure out what to do in terms of providing some anesthesia so that you can reduce his shoulder. So for this kind of shoulder disease, you're gonna have to do a much more axial block, looking at the actual brachial plexus itself. Specifically with this, you can do, there's a couple of different blocks you can do. The one I'm gonna talk about is the interscalene block. And the interscalene block, you get analgesia of C5 through 7. And this is the innervation. So you can see the dermal-tomal distribution here. But if you look at the bony distribution, you can see that you really do get good analgesia of the shoulder itself. And that's what you're looking for. So this block is great, not only for shoulder dislocations, but also for some proximal or mid-humeral fractures, and then any kind of like abscess or laceration up on the upper part of the arm that you may need to repair. So what's really great about this block is that there's a lot of evidence, or there's some evidence, there's good evidence that it reduces length of stay in the emergency department. So I wanted to highlight a couple of studies that I found. The first one by Blyvus was a randomized trial where folks were randomized to either procedural sedation with etomidate or an interscalene block for reduction of a shoulder dislocation. And there was a significant difference in terms of length of stay that favored the interscalene block over procedural sedation. There was also a significant difference in terms of one-on-one healthcare provider time that was required for those patients. So if you think about everything that goes into a procedural sedation, getting everything set up, the nursing, the timeouts, all of that, you know, I would assume that that's likely what led to those differences. In this study, the patients had the same level of patient satisfaction, and they had the same level of pain reduction. A more recent study down in 2017 also randomized folks to either procedural sedation, this time with fentanyl and propofol, versus an interscalene block. Also found a significant difference between length of stay that favored an interscalene block. That said, in this study, they did find that there was a little bit less pain relief in the interscalene block group, and there was marginally less patient satisfaction. Either way, I think that this is a fantastic block to try. And from what I can tell on looking at websites of hospitals across the nations, it looks like there are some places where this is kind of becoming the norm. So for your interscalene block, okay, so for your interscalene block, what you need to remember is that the brachial plexus exits kind of the neck area through the medial scalene and the anterior scalene muscles. And it's kind of right above the subclavian artery. And so those are going to be your landmarks that you need to keep in mind, in addition to the clavicle. So in cross section, what you end up looking at before you do your injection is the middle scalene, the anterior scalene, and then the brachial plexus right here in the middle. On the ultrasound, they call it the stoplight sign, because it looks like 3 little circles. And that's going to be your landmark to show you that you're in the right place. And you basically want to inject right around those circles to get the anesthetic where you want it to go. In terms of actually finding that area, because that's half the battle, is figuring out where you actually need to go. I think, there's a lot of ways to go about it. The one that I found that seems the most straightforward and easiest to follow is to actually start down at the clavicle. And so what you can see here is he's got the probe just above the clavicle, parallel to it. And this is the view that you're going to have. You're going to have the subclavian artery here. You see the first rib, you see the pleura down here, and then this is not what's happening. Ugh. There we go. Right there, this bunch of grapes right here is your brachial plexus. And what you're going to do is you're going to follow that brachial plexus up until you see the scalenes and your stoplight sign, just like this. So look at him following it up. The scalenes come into view and you get your stop sign. So following it up, scalene, stoplight sign. And then this is what you've got here. So you've got your anterior scalene, your middle scalene, your stoplight sign with your brachial plexus, and this is where your needle is going to come in and deposit anesthetic. Important thing to think about if you are going to do an interscalene block is that your phrenic nerve is also kind of right in that area. So it is almost an expected complication within the anesthesia literature, which obviously are doing much longer acting blocks and often doing continuous blocks. But it's almost expected that some number of patients with an interscalene block will have a phrenic nerve palsy as a result. It's just because everything is just in such close proximity right there, and the amount of volume that's going in, it's likely that the anesthetic will kind of distribute and affect the phrenic nerve to some extent. However, what I was able to find in the literature, it seems that a large portion of these phrenic nerve palsies are actually not clinically significant. You can measure it with spirometry, but it's not necessarily affecting the patient clinically. But there may be some patients who are affected. And so what things that you can do to kind of decrease those risks are using the least volume and the lowest concentration that you feel you can. There have actually been specific studies looking at this, and it was shown to decrease the likelihood of phrenic nerve palsy. Also think about your patient, like we talked about earlier, looking at the clinical indications for the block. Look at your patient's comorbidities. Someone who has really bad COPD or a really bad restrictive lung disease, you may not want to do this block on, because if they lose that phrenic nerve, that may be something that is really clinically significant for them. Similarly, if you have someone who has a pre-existing phrenic nerve palsy on the other side, you look at the patient, obviously, but you may want to think about doing something different, because if you take away both of their phrenic nerves, then that could potentially be catastrophic for them. And so taking that all into consideration and understanding that, yes, even if you do affect the phrenic nerve, often it will not be clinically significant. It's a good idea to have these folks on a monitor and potentially have end tidal, just to give you a heads up if there is a change in their status. So in summary, think about when you're doing a nerve block, especially on the upper extremity, that your skin innervations, your bone innervations are not going to be the same. Know your anatomy. So know your cross-sectional anatomy. We don't always think in cross sections. It's easy to get confused when you're looking at it in ultrasound. So I think there's absolutely no shame in doing a Google search and getting a quick image of what a cross section of the area that you want to anesthetize looks like, and then looking with the ultrasound before you even get your supplies ready to make sure that you can actually identify those structures. Think about the clinical indications. So think about, do I need a long block? Do I need a short block? Is it safe to do a long block on this patient? Is it safe to do a short block on this patient? So that not only are you sure that you're being safe with your patient, but so that you can also discuss it with your consulting clinicians who may be concerned about neurological exams. And then finally, just safety overall. I like to think of the 3 V's: volume, vasculature, and vicinity. So think about the volume you're using. If you can reduce the volumes, particularly with axial blocks like the brachial plexus, to decrease the likelihood of affecting phrenic nerve, then go ahead and do that. Think about the vasculature that's surrounding it. And anytime, I think it's a good practice to anytime you're putting a needle into the skin with an ultrasound, be able to know kind of where the vasculature is in relation to your needle. And then just think about other things that are in the vicinity that you could potentially damage. Are there other large nerve bundles in the vicinity that may be affected by not only your needle puncture, but also by the anesthetic that you're putting in? I want to thank the ultrasound team for helping me with this. That's Dr. Hannison, Kilpatrick, Allen, Lee, and Walsh. And that's it.